me a thumbs up if the slides are visible. Great. So this is the agenda for today. Yeah. So the topic for today is phenomenology to management, the psycho-immunoendocrine interface in case of a Hashimoto's encephalopathy. Now let's put that Hashimoto's encephalopathy as a query because the diagnostic assessment for the case is midway. We will take your inputs and we'll probably go ahead with further diagnostic plan for the case. The presenter for today would be Dr. Swayanka. Dr. Swayanka Samantra is a senior resident working at KIMS Bhubaneswar in the Department of Psychiatry. I am Dr. Udit Panda and I'll be moderating the session. The case in charge for the case in our ward is Dr. Jaiprakash Russell Ravan, who is also the professor and department head of psychiatry at KIMS. He's part of the discussion. Then we have been fortunate to have been joined by Dr. Prashant Pradhan. Dr. Prashant sir is a professor of immunology and department head at KIMS Bhubaneswar. He is also part of the discussion today. And we are expecting Dr. Swayamsiddha Mangaraj, who is an endocrinologist. He would also be joining us within the next 5 to 10 minutes. He's an associate professor of endocrinology at IMS and Som Hospital, Bhubaneswar. So that's roughly the agenda. I have a small announcement to make before I hand over the microphone to Swayanka to continue the case presentation. So for the first 4 sessions, our team has been fishing out cases and they have been presenting the cases in front of the team, in front of the audience. And we want people from all over India to bring cases that they find interesting and bring it to this forum and present it. You can write down a brief summary of any case you find interesting and mail it to us at this mail ID that is on the screen, mondayroundtable@gmail.com. We'll evaluate the case. If we find it appropriate to be presented in the forum, we'll get back to you. If you want any hand-holding and mentoring, we're willing to do that as well. Then we'll fix a slot and we'll probably allow you to present it in the forum. So that's a request, an honest request. I hope young people who have joined the program in the past as well as would be joining us in future, they bring interesting cases to us so that we also get to learn. Okay, that finishes the introduction, and I welcome Dr. Swayanka, and I hand over the mic to her to project her case slides and start presenting. I think we have 23 participants, so it's a good time to start presenting the case.
Am I audible?
Yeah, fine. You can make your slides full screen and then start presenting.
My slides are visible?
Yes.
Is it visible? Okay. Good evening. I'm Dr. Swayanka Samantra. I'm senior resident from KIMS Bhubaneswar. I'm going to present on the topic phenomenology to management, psycho-immuno-endocrine interface in a case of Hashimoto's encephalitis. I'll start with the demographic details. A 59-year-old Hindu female from married housewife, studied up to 10th standard with mother tongue Odia, coming from a rural low socioeconomic status with informant son, the information being reliable and adequate. She came with the following chief complaints: crying spells, irritability and using abusive words, poor grooming and hygiene since 2 years, forgetfulness, impairment in socio-occupational functioning since 1 year. The onset was insidious, duration was for 2 years, and the course was continuous and progressive. The precipitating factors were the following. She was displaced from her inherited house by brother and sister-in-law. There were property issues and their house was destroyed in fire due to some electrical wiring glitch. Starting with the HOPI, 2 years back during COVID lockdown, following property issues and fire mishaps, the patient became sad and had frequent crying spells. She was worried about her family's future and her son's marriage mostly, and became irritable and frustrated for the same reasons. She would always mutter about building the house, and when her son and her husband were not able to do so, she would abuse them, she would get agitated, she would shout at them, which was not her normal self earlier. She was a very fine lady who involved herself in grooming, hygiene, and kept the house clean. She was very particular about the cleanliness of the house. But since the last 2 years, all of these behaviors have reduced. Like she is paying less attention to grooming and hygiene. Earlier, she was an active lady who was carrying out household chores as well as farming work. But since the last 1 year, she has become very lethargic. She is not as energetic as before, and her functioning in the activities of daily living has also been impaired. She remains absent-minded and also forgetful. Sometimes she is found wandering as she would forget the directions. She is unable to remember the names of her family members, even the day-to-day normal objects that she uses. She would forget that she has taken meals and she would eat more than one at a time. She started taking raw vegetables, unlike before. Even her interaction with her family members and village people has had reduced. And recently, she had developed visiting to the temple 2 to 3 times because she would forget that she has already visited the temple. However, her religious rituals at home had reduced, like all her other daily activities. Her sleep was also significantly affected. Earlier, she used to sleep for like 5 to 6 hours in a day, but now she is sleeping like 2 to 3 hours at night. Following all these symptoms, she was taken to a local psychiatrist and she was started on psychotropics for 1 month in April 2022. But there was no improvement, and however, there was slight improvement in the sleep. In the past treatment, there has been no hospitalization. She's not a known case of hypertension, diabetes, or asthma. She's not a known case of any prior neurological or medical illness. She has never had a head injury or any severe episode. In treatment history, she was given oral dose of risperidone 4 milligram, quetiapine 300 milligram, zolpidem 10 milligram, and imipramine 10 milligram for 1 month, but there was no response. However, there were side effects such as oversedation. She was also treated with Ayurvedic and homeopathic treatment in the past 1 month. She lives with her husband and son, and her daughter is married with 2 kids. There has been no family history of psychiatric illnesses. Patient and her husband, they earn money through farming. The possible stresses are IPR interpersonal issues with the elder brother-in-law and sister-in-law. In personal history, she is a 10th graduate. She has no substance abuse and she has attained menopause. Pre-morbid personality, she was an optimistic person. She had cordial relations with her family members, villagers. She was a hardworking housewife who was very particular about cleanliness. She had a full range of mood. She was expressive. There was appropriate control over emotions. There were no anger outbursts. She was outspoken and was very helpful, religious, moral, and conscious about her well-being. There was no substance abuse or habit. And her eating and sleeping patterns were regular. My inference was pre-morbidly, she was well-adjusted. On physical examination, she had an average build. There was no pallor, cyanosis, clubbing, or icterus or edema. However, she was not oriented to time, place, and person. On physical examination, all the systemic examinations were within normal limits. There was no, on CNS examination, there was no neck stiffness. It was negative for Kernig's, Grudzinski, and normal for all cranial nerve and other neurological examination. Since we could not do mental state examination, we applied the Kirby's method. She was not spontaneous. Occasional acts of assaultiveness was there. She was trying to jump out of the window multiple times. She looked untidy and unkempt. Her behavior was irritable. She was mostly lying on the bed in an awkward position. She looked distressed. Her eyes were open. Eye contact was not initiated. Corneal reflex was present. She was not responding to simple commands. She was very uncooperative. However, there was no automatic obedience, echolalia, or echopraxia. She had no rigidity or waxy flexibility or Gagenhalten. Her speech was irrelevant at times. Mostly, she was preoccupied with building her house and the fire incident. Her vitals were stable. So, as the patient was unmanageable at home, she was admitted in our department. And for the management of acute symptoms, parenteral dose of haloperidol 10 milligram and Phenergan 50 milligram was given stat. We did the routine investigation. Her CBC, LFT, RFT, lipid, and glucose profile were within normal limits. However, the TSH was more than 100 micro international units per milliliter. And the T4 was also reduced. That was 4.45 microgram per deciliter. When we did FT4, it was also reduced. That was 0.59 nanogram per deciliter. Then anti-TPO was more than 1,238 international units per milliliter. On NCCT, we found that there was cerebral and cerebellar atrophy. There was chronic lacunar infarct noted in the bilateral gangliocapsular region. The patient was started on olanzapine 10 milligram per day in divided doses, and it was augmented later on with haloperidol 5 milligram per day as the agitation persisted. Endocrinology consultation was done, and thyroxine 50 microgram was started and titrated up to 88 microgram. Rheumatology consultation was done, and parenteral dexamethasone 8 milligram was initiated for 7 days along with vitamin D and calcium supplementation. Neurology consultation was done for chronic infarct, and ecospirin was started 75 milligram and atorvastatin 20 milligram orally. Later on, the parenteral dexamethasone was replaced by 50 milligram of prednisolone per day. Today is day 32 of admission. The agitation and aggression has reduced. Affect is cheerful. Sleep has also improved. However, the patient is still uncooperative, still preoccupied with the fire incident, and continuously demanding her son to complete the new house, the construction of the new house. She is still unable to name the objects and family members, and even if she is oriented to time and person, she is still disoriented to, oriented to place and person, she is still disoriented to time. No MSC could be done and MMLC could not be administered. CSF study and MRI has been planned from neurological point of view in order to rule out infective, toxic, and metabolic causes. Our provisional diagnosis is late onset psychosis plus other delirium and Hashimoto's encephalopathy. Now coming to the discussion, Hashimoto's thyroiditis is one of the most common thyroiditis, especially.
Well, let us discuss about the case maybe for some time.
Okay.
Then.
Yes, sir.
So,
Dr. Udit, may I just summarize?
Just probably, I thought it would be a good idea for someone who has not seen the case to brief people what all happened in the case, and maybe will come to you. So this is the case of a 59-year-old female who is having behavioral as well as mood symptoms for the last 2 years with a very fluctuating course. This seems to be the cognitive deterioration seems to be very prominent for the last 1 year with an alteration in the sensorium as well. There has been poor response to psychotropic treatment in the past, and she was hospitalized due of unmanageability. In the ward during the routine investigation, it was found out that her anti-TPO antibody titer was through the roof. It was very, very high. So apparently, apart from antipsychotics, she has also been given bolus or high dose of steroids, high potent steroids, and with that, her symptoms seems to have remitted. Swanka, have I got things right?
Yes, sir. We had started dexamethasone and thyroxine along with antipsychotics.
This brings me to a point where I have multiple differentials speaking through my head. So we'll go to the primary consultant in charge of the case, Dr. Jaiprakash Rasalapan, to gain some more clarity. Sir, over to you. Please go ahead with the discussion.
Yeah, it's a very good evening. These people who have joined little late. This lady who actually had a depressive features for a period of a year, but the most striking thing for which the patient has been brought for admission was this fluctuating consciousness or kind of having the symptomatology having an organic flavor. What do I mean by saying organic flavor is the presentations of this disorientation was not constant throughout the day. At times she would be confused and she would be not able to identify people and would talk something irrelevant. But at times there will be some relevant speech where she would request in an agitated way to the son that you take care of the house, you build the house, and so on. So from that, we had a suspicion that probably we are not seeing the usual depression with agitation, which we see in the late onset depression or late onset psychosis. So that actually put a red flag in our thinking process, where Dr. Jigyasa, me, and our team started thinking probably there is something else. And as for our uh, clinical suspicion that probably it is a case of thyroid dysfunction. And when we got the TPO, then we thought it probably a Hashimoto encephalopathy. And from where we started getting inputs from the immunology department uh, from Dr. Prashant sir. So, as you are saying very rightly, the clinical differential diagnosis in this type of presentation, when fluctuating consciousness with in a background of depression and agitation, and could be because of a viral encephalitis, or it could be because of a neoplastic presentation. It can be because of multi-lymphatic state in a
Sir, you got muted.
conditions like metastatic brain lesions can also present like this type of presentation. So it was this series of cases which has been seen over a period of time, maybe 3, 4, which have this similar kind of presentation. The one commonality is that mostly this happens in female, and they don't tolerate to antipsychotic. When you give antipsychotic, there will be worsening of agitation, confusion would be there. So when the psychiatric resident or faculty, when they encounter patients with elderly or age group around 50 to 60, and they have abnormal speech and abnormal thought content, but antipsychotic worsening the situation, that should be another red flag. Probably we are dealing something else, not a um, axis 1 depression with psychosis or late onset psychosis. So
Sir,
I
in
think
that slide, there are two queries in the chat box which are probably relevant here. The first one is why the diagnosis of a reversible cause of dementia is not considered. In the sense, why dementia is not the primary diagnosis, with maybe the symptoms being explained by the behavioral and psychological symptoms of dementia. And Dr. Asi is also asking whether the psychotic symptoms can be due to the deranged thyroid TSS level. So, what would be your response to that?
One is dementia. When you see Alzheimer's kind of dementia, and with, on top of that, when they are delirium, they will have almost similar picture. But once we control the agitation, once you know that electrolyte is normal and other things are in a normal range, then you do a MMSC and all, you will get a clear prominent deficit in the recent memory, and the pattern of clinical presentation will be mostly in form of forgetfulness and cognitive area, as well as some of the apraxia or aphasia will be there. But this case was not fitting into that clinical pattern of Alzheimer's with its complication. So it's definitely a difficult case, clinically very difficult to tease out. Maybe Dr. Jigyasa will give a brief account of what she was thinking and how we handled, and then we can go to Prashant sir and our endocrinologists, for their opinion.
Yeah. Why is it not a reversible dementia?
Yeah, it is possible that dementia can be a differential, but in this particular case, the dramatic onset was something which was quite striking, as opposed to in usual dementias where there is at least a subacute to an insidious onset. So maybe that is why that differential is not something that we considered initially. And the presentation also was, I would say, rather than disorientation, it was like maybe she was not comprehending what we were trying to say. Maybe the comprehension per se was impaired, because no matter whatever and however we tried to assess this particular patient, it was she was always talking about that one particular, the preoccupation about that fire incident. So I'm not very sure if she was understanding what we were thinking, and that is why we also thought a differential of maybe she had some sensory aphasia or Wernicke's aphasia. So those were the differentials which we also considered. So, but when we got the TSH and the anti-TPO levels to be that high, so that was quite striking. And the T4 level was not that low also. It was just mildly low, below the normal. So initially when we took the endocrine consultation, they started with thyroxine, but despite that, the levels were not getting corrected, and the behavior agitation was a challenge for us in the ward. She had to be restrained multiple times, and being on the elderly side of the age, we were not able to load her with antipsychotics as well. So these were the challenges that we faced, and maybe we'll seek the opinion of other specialists. Over to Dr. Udit Panda.
Yeah, thank you. So we'll request Dr. Prasant to see. He has also been part of the treating team. He has been. Sir, would you be kind enough to give your insights into the case?
Yeah, basically, good evening to all. And in fact, my job was very simple because it was already diagnosed. And so I didn't do much. Basically, I was just fitting into the kind of this various parts into one area and then make a final diagnosis. And this is very important to remember few points. This case actually teaches us many things. One is like there are no watertight compartment in diseases. One thing one must remember, and one should keep the mind open even if you think of a kind of a primary psychiatric illness versus an organic disorder. As the Dr. Jayaprakash was already saying, mentioning, there are certain red flag signs which are in favor of an organic disorder. That was the first level of suspicion. Number two, when you investigate such a patient, where do you stop or where do you start? That is what is the question. And I must congratulate the person who actually started. Like the way, do you send routinely the thyroid function, anti-TPO in all, or do you just did it kind of a just try and find out whether there is anything? So if it was a kind of a strong suspicion, then it is still very good. And it is important to suspect in cases where they are middle-aged, like ladies like this, 50 years and plus, females, much more common. Then autoimmune diseases can start with Hashimoto thyroiditis, lupus, primary Sjogren's, and many other. And in a situation like this, where the antibody is very high with the psychiatric manifestations, although the duration is quite prolonged now by 2 years, so once you delay in make a diagnosis in such a case, probably the response also might get slower or maybe a bit late. But yes, all said and done, it's a case of probably Hashimoto encephalopathy. And there are infarcts in the brain which are not explained by this primary illness, because you don't see an infarct in case of Hashimoto encephalopathy. Most of the time, it's the CSF which is abnormal, and you just see the MRI images, most of the time it is normal. So there must be another component which may be playing a role, like small infarcts are there. But yes, we'll see the response to steroids, and then maybe you can take a call, which is the most important pathophysiology in this particular patient. Over to you, Dr. Udit.
Sir, I have a query of my own here. Is it possible that the deposition of the immune complexes in Hashimoto's encephalopathy can actually cause stroke or a stroke-like syndrome?
Not really. That has not been documented. It's basically the because many things are not described in a rare disease like this, where you have very little description about what exactly goes wrong. Basically, these are all what I would say like primary CNS vasculitic disorders. This is kind of encephalomyelitis, not vasculitis. Vasculitic disorders, you expect infarcts and other things. What will be interesting to look at is we'll do certain more antibodies. Maybe we did not do it to initial part, but we'll do antinuclear antibody, anticardiolipin, and other antibodies which are likely to cause infarct in the same patient. And maybe it is an extended spectrum of this combination of pre-lupus kind of thing, antiphospholipid syndrome, and Hashimoto encephalopathy in the same patient. So probably we'll do few more tests, and then maybe it will be much more clearer.
So one more query. I have a few differentials, jumping in my mind. The first one is that anti-NMDA encephalitis. That is something that kind of presents like this. Then maybe prion diseases or other forms of encephalopathy, they can also present like this. Only the presence of a high titer of anti-TPO, does it indicate that other conditions are ruled out, or we have to take an effort to maybe do some other investigations to rule other conditions out?
No, basically, you can look at either way. Like, but my aim will be like, once you have already found out one very specific entity, and then the antibody level are so high, it is important that you look at the response to therapy. And if you do not get a response, probably you need to look at the other etiologies.
Okay, thank you, sir. We'll probably move next to Dr. Swayam Sindha Mangraj. He is an endocrinologist. Maybe he will put some more light into the topic. Dr. Swayam Sindha, if you are around, please.
Okay, thanks, Dr. Udit. Am I audible?
Yeah.
Okay, fine. So, good evening, everyone. I think we had a wonderful discussion at this juncture. So, I would like to make few points very clear out here. Hashimoto encephalopathy is still a diagnosis of exclusion after you have ruled out every other disorder like toxic, metabolic, inflammatory. Then only you can label the diagnosis as Hashimoto's encephalopathy. First thing is, Hashimoto thyroiditis is a very common disorder. If you look at the numbers, almost, let's say, 5 to 10% of the women would qualify to have an autoantibody to thyroid gland, and many of them would be having either subclinical thyroid dysfunction or overt hypothyroidism. However, encephalopathy due to deficiency of the hormones, let's say myxedema coma, they show a dramatic response to replacement of hormones. Unlike in Hashimoto encephalopathy, where the hormone replacement may not give you any benefit with regards to the improvement in the neurocognitive function. The treatment of choice remains steroid. So that's why perhaps sometimes it was labeled as steroid responsive encephalopathy associated with autoimmune thyroiditis, and different nomenclature has been put forth for that. There is a distinct diagnostic criteria for diagnosis of this entity. The thing is, majority of Hashimoto encephalopathy, which we have seen, is usually diagnosed by a neurologist because they have to rule out MS. They need to send a CSF oligoanticoagulation bands. They need to set autoimmune profile for the CSF to rule out autoimmune encephalopathy and other toxic things. Once these are ruled out, then only they label the case as it could be a Hashimoto encephalopathy. In this case, because the patient was an overt hypothyroid, patient did have TSH way above the 10 with deficiency of T4, and anti-TPO antibodies were also high. Hence, perhaps replacement of T4 seems a prudent choice, but that may not improve the neurocognitive outcome of this particular patient, because majority of Hashimoto encephalopathy, which we have seen is a very rare disease, are usually euthyroid. Because other differentials are once ruled out, then someone asked to send a autoantibody, namely anti-TPO, that comes out to be positive. Then subsequently, a differential of Hashimoto encephalopathy comes into the picture. And this anti-TPO antibody, previously they used to give a titer, let's say more than 200. If it's more than that particular threshold, the likelihood of disease is very high. But that in the recent years, that cutoff has been now taken a back end, and now only positivity of autoantibody is just what is told to be associated with Hashimoto encephalopathy. So treatment response to steroid, which was sine qua non for the diagnosis, is also now not that diagnostic. Means around 20 to 30% patients who were actually Hashimoto encephalopathy may not respond to the steroids in the conventional way as it was previously thought. And once you give the high dose steroid, there is some improvement, then taper it to oral steroids, that response may not be like what is conventionally thought of to be in the case of Hashimoto encephalopathy. So perhaps for me, before eventually diagnosing the condition to be Hashimoto encephalopathy, other common or less common causes of vascular, even vasculitis, toxic or autoimmune encephalopathy should be ruled out ideally in this scenario. Because there are many points in favor of including response to steroids, perhaps the patient may have Hashimoto encephalopathy. But if you look at the prevalence of Hashimoto thyroiditis versus the encephalopathy, a number is on the millions of individuals who suffer from subclinical thyroid dysfunction or overt thyroid dysfunction. But if you review the literature of Hashimoto encephalopathy, I think the cases would be less than 1,000. So perhaps the disease is indeed very, very rare, because we are still not able to give a actual diagnostic protocol how it should be diagnosed. The sensitivity and specificity of the biomarkers, including anti-TPO, which was thought to be gold standard. It is not like that. One question which Dr. Udit said, that perhaps could the anti-TPO antibody, which is primarily directed toward the thyroid autoantigens, could be directed to other part of the CNS. But even few brilliant studies have been done which have looked into the tissue level of these suspected patients. There also they could not find any tissue deposition of this autoantibody related immune complexes, or even the levels of autoantibody, let's say anti-TPO antibody in the CSF and serum may not be that marked. So I think these are all gray zones. Having said that, but if your patient responds to steroids in this background, then definitely putting a diagnosis of Hashimoto encephalopathy seems prudent. But other conditions which might lead to clinical pictures like this, like cases of CJD, that is a prion disease, cases of Alzheimer's, cases of dementia, these are all have been mislabeled as HE in the initial part. That later on, when the differentials were looked out, they came out to be something other. So I think if you look at and go to the literature of Hashimoto encephalopathy, the things become more and more complex and you become more confused. So if you start reading the literature at one end of point of time, when you start, it is quite clearer that if these findings are there, I am perhaps dealing with a case of Hashimoto encephalopathy. But if you do a thorough literature review, the things are completely in the gray zone.
Okay, thank you. So that
I have a question to our expert, that if this kind of conditions remain undiagnosed, let's say this is Hashimoto related encephalopathy, if remain undiagnosed for a long time, which could have happened in this patient, that can this kind of encephalopathy which is not treated for a long time can lead to more of cognitive decline? Is it so? I try to get some literature about that. What is clinically or like from the endocrinologist point of view? We want to know.
I think the answer would be definite yes, because cases have been treated as refractory status epilepticus with the similar presentation of Hashimoto encephalopathy. Eventually, they turned out to be Hashimoto encephalopathy. So I think all types of neurocognitive decline, including significant morbidity and mortality, have been described in this particular scenarios, because these people may have underlying other comorbidities which may get jeopardized if this case is misdiagnosed. So I for that very reason, the disease, if at all it is responding to steroids, I think we are on a strong ground that perhaps we are dealing with this entity and alone.
Okay.
So I was reading about a triad. Apparently, there's you have a host of neuropsychiatric syndrome like depression or psychosis or maybe cognitive impairment, along with high titers of either anti-TPO or anti-thyroglobulin antibodies and a good response to steroids. Then it makes a good case for Hashimoto's encephalopathy, provided other causes are ruled out. Is that true, Dr. Swayam Siddha?
And that provided is the head which should be underlined and kept in bold. So I always told that it is a diagnosis of exclusion. Other disorders have to be ruled out mandatorily before labeling it as HE.
Yeah, my doubts were because if we're considering other autoimmune encephalitis as well for the case, they will also be responsive to steroid treatments, no? So that is something that we need to think of. Maybe the CVA is even independent, that Dr. Prasad was mentioning, and this whole behavioral and cognitive symptoms might be a consequence of CVA. Is that a possibility? Dr. Jayaprakash or Dr. Jignasa, can you please put some light on that?
So my thing is, if this what being repeatedly stressed on about the ruling out other diagnosis in domain of psychiatry, people previously think that you rule out all other conditions and then make a diagnosis of depression or psychosis and all. Now, or dissociation even. Now we know that it cannot, psychiatric diagnosis cannot be diagnosis of exclusion. Even in the first point, panic disorder, we know the pattern and we can make a good clinical working diagnosis of panic disorder. In this case, it becomes more complex because in the background of depressive features and cognitive decline, as well as this kind of laboratory parameters, points towards this Hashimoto encephalopathy phenomenon. But as rightly mentioned by our endocrinologist expert, we are very much mindful about doing the MRI and CSF study, which will rule out most of the differentials, like whether it is a NMDA encephalopathy or any other conditions. So, but initially stage in the first 2 weeks when we were struggling with this patient was not in a state to put into for MRI or any other imaging or CSF study, and family was in very desperate. This is now today. Soinka was saying that now she has been settling. She would be now comfortably go into the machine to get a imaging done, and CSF also will do. Probably will get more insight into the psychopathology or any other comorbid condition. As our Prashant sir was saying, for the time being, clinically, we can keep or biochemically, we can keep Hashimoto encephalopathy and treat. But my question is, how long we should keep steroid, and what is in the future about this steroid, and how long we should keep? Is there any guideline for that? So, Prashant sir.
Can answer that.
Yeah, basically for any autoimmune disease to settle, it takes about 4 to 6 weeks of steroid at a dose of 1 milligram per kg per day. That's what we have started, and we'll slowly taper down after 4 to 6 weeks. Possibly by 4 weeks, when the response is maximally, you can expect a maximum response by 4 weeks. And after that, we'll taper by 5 to 10 milligram every week or every 15 days, depending on the patient's response and holding on to the response to steroids. And once there is a steroid of 7.5 milligram below that, we will try to be more cautious. And if there is any relapse, then we have to add on steroid sparing agents like methotrexate, azathioprine, mycophenolate, based on their tolerability, efficacy, and many other issues. So that time will only will say. But as of now, we have decided to give at least for 4 weeks.
Okay. So that brings us to the next question. Sir, what about treatment with antipsychotics now? Dr. Deyaprakash, would you be willing to answer that?
In the last 2 cases which you had seen, eventually they did not require antipsychotic. We started reducing tapering the dose of antipsychotic, and this type of patients will not require much of antipsychotic for a longer period of time, because the pathology is somewhere else where it is steroid responsive, and so we can reduce the antipsychotic, keep it as minimum. Probably in the review we can stop and see whether the patient has any other background depression or something which can be treated as it manifests. But antipsychotic, I think, should be reduced as quickly and as tolerably possible.
Okay. So as of now, Swayanka, is the patient on antipsychotics?
Yes, sir. The patient is on haloperidol 2.5 milligram and olanzapine 10 milligram.
Okay, so we have another 5 minutes maybe left. We'll take up any questions from the participating students. Anyone who has a query which is not addressed. Dr. Narasimha, would you like to ask another question? I'm not sure whether the question was addressed adequately or not.
No, I think the question has been addressed adequately. And yeah, it was a wonderful discussion. Thank you.
Okay. Dr. Shiv Kumar is asking whether steroids are not going to worsen the psychotic symptoms. Is it okay if I respond to that? Quite fascinatingly, the people with Hashimoto's disease, there will be a larger chunk of the patients who are going to remit with steroids, not worsen with steroids. The steroid will actually, take away all the psychotic symptoms. After that, the steroids can be tapered and stopped. So that is the magic of steroids in this kind.
We have to understand that this steroid will address the pathology where the problem is happening, and if that is being taken care of, then there will be no dysphoria, no psychosis, no confusion. So that is our height of anticipation, or we are enthusiastically waiting for that to happen. But I think we are going in the right direction with the guidance of Prashant sir.
Okay, in that sense, I have a question for Dr. Prashant now. Is it possible, sir, that we can use anti-TPO labels to monitor the progress of the case? Does the level decrease as we are treating them with steroid, and how does that happen?
Possibly no, because these antibodies are sometimes the level do not correlate with the disease activity. That's what I was just looking at the literature. And what would be, there will be not a proper single guide in these patients, because as I told you in the beginning also, like if the number of cases in the literature are less or less known facts about this disease, so it is to be still being written. So really at this point, we do not know whether these antibodies level decline will happen or not. But in a particular patient, yes, we can look at it while on treatment and see.
Okay. Thank you.
I have just one question. Can I ask?
Yeah, please go ahead.
Yeah. So suppose the patient did not have encephalopathy and no behavior problems. So then also is steroid indicated? Like, I'm not very sure.
Maybe
Probably not. Yes, I have to answer this. Probably not. Steroid is not indicated because these antibodies are like, they are in most of these patients with autoimmune thyroiditis. But not every autoantibody causes a disease. Like many of us have antibody to nucleus, like antinuclear antibody in the general population as well. But not everybody develop lupus, right? So it's the same thing happens in many of these diseases. Why you develop a particular disease is based on many other things. So it is not the antibody alone which needs treatment, but but only when you have a disease only you have to treat. That's it.
Like we should not treat the antibody, we should treat the patients with symptoms and other.
Yes, of course.
Sir, that leads to the next question. Apart from corticosteroids, do you think we have any other therapeutic avenue to treat this?
Yeah, you can give IVIG for a very quick response, or you can do even plasma exchange if you are still having a poor response to treatment. And once these patients they respond well to steroid, you have drugs like rituximab, anti-B cell therapy, or you can give azathioprine, cyclophosphamide, or micro. Many choices are there. But if you want a quicker response, maybe I would prefer IVIG or plasma exchange. IVIG would be a better choice.
Okay.
Definitely.
Okay. Any further questions? Because we are hitting 7:45, would like to be on time. Anybody who want to ask a final question before we end the program?
I think Soyanka wants to tell something about the criteria of Hashimoto. Otherwise, he will not able to.
Yeah, Soyanka has made a slide. So Soyanka, you can give us the criteria and then maybe we can wrap it up.
Okay, sir. Is it visible, the slide?
It is.
Okay, so the diagnostic criteria, it involves the clinical presentation, which includes encephalopathy with cognitive impairment, encephalopathy with psychiatric manifestation, encephalopathy with partial or generalized seizures, with focal neurological deficits or alteration of consciousness, and encephalopathy with dystonia. These are 5 different types of clinical presentation. Lab tests that we have to do is the presence of high titer anti-TPO antibody, exclusion of neurological diseases, as earlier mentioned, that neurological infection, toxic and metabolic disorders have to be excluded. And response to treatment, patient's neurological status usually returns to the baseline after it is treated with steroids. So this is the diagnostic criteria that was obtained in one of the literatures for Hashimoto's encephalopathy.
So
and I would like to also present about how it can present. It can, the hallmark of HE, it can be an altered mentation like confusion, plus or minus accompanying seizure. Seizures are present in almost 2/3 of the patient. Myoclonus can also be present. It is present in 38% of the patient. And there can be 2 patterns of cognitive dysfunction. One is stroke-like pattern, which is acute and subacute in onset. And another one is very gradual, diffuse, progressive pattern, which our patient had. It sometimes results in dementia, hallucination, or even coma in severe cases.
Okay.
So that's all about the presentation.
Of the 4 diagnostic criteria that you mentioned, the third one is something that we're little shaky on. So, but rest matching up. The third one is a big one. No, we have to rule out a lot of things.
Yes.
Yeah, next few days we should concentrate on ruling out other comorbid or co-occurring problem like neurological things and toxic thing. And as Soyanka has mentioned, we'll do that definitely. Yeah.
Okay, so big thanks to our discussants, Dr. Prasant and Dr. Sam Siddha, for their kind enough time, giving the kind of time to us to be able to participate and make this discussion rich. Thanks a lot, sir. I now final request for all the residents who have been participating in this forum from different institutions. Please, if you have any case that you find interesting in either diagnosis or management challenges, write down a short summary and mail it to us in the mail ID mondayroundtable@gmail.com. We'll evaluate the case and maybe get back to you to discuss whether it is fit to be presented in the forum. We would love that people from other institutes come over and start presenting here. Okay, that's it from my side. Thank you so much, everybody. Have a good night.
Thank you. Thank you.
Good night. Good
Thank you,
night.
everybody.
Thank
Thank
you.
you, Surenka and Basant sir and Swingsit.
Okay. Good night.
Thank you, sir. Good night.
Good night.
So from here, I'm ending this meeting. Thank you, all of you.
Yeah.